So what happened to our 59-year-old gentleman who had AML and this history of hypertension, and he began chemotherapy treatment? So we like to see these patients, of course, before they begin their chemotherapy. We do the echocardiogram. His ejection fraction is 66%. We look at his global longitudinal peak systolic strain, and it's minus 17.3%, just a little below sort of the normal reference value. But his ejection fraction is normal at 66%. We remind ourselves again of the EACVI and the ASE's definition now for chemotherapeutic-related cardiac dysfunction, a reduction in EF by greater than 10% to a value less than 53%. And if we have a baseline strain value, remind ourselves that a change less than 8% may not be meaningful, greater than 15% very likely to be abnormal. And here we just look at myocardial strain. Is it associated with adverse clinical events? And again, ejection fraction, if it's normal at baseline, isn't very discriminatory about which patients may end up with cardiotoxicity or changes in ventricular function. However, global longitudinal strain was associated with cardiac events when it's abnormal, even in those individuals up front that have a normal ejection fraction. And so you can see here that yes, clinical variables add to ejection fraction. Remember things like obesity, hypertension, extremes of age, and so forth. But if we add a measure of global longitudinal strain, it has even greater discriminatory impact to identify those patients at risk. And in this study, they used a value of about minus 17.5%. And this threshold identified patients that did not develop cardiac events. So if you have a normal strain, it has a good negative predictive value. It has a modest positive predictive value, about 60% or so. But its biggest strength is in its negative predictive value. So our patient began with an ejection fraction of 66%. 2 months later, the ejection fraction dropped to 58%. That's a 12% relative reduction in ejection fraction. Does it reach the threshold? Well, it is greater than 10%, but it's not to a value less than 53%. If we look, however, at the global longitudinal strain, remember it started at minus 17. Here I just show you a troponin T, a biomarker we often measure as well. But 2 months later, the ejection fraction dropped, but so did the strain from minus 17 to minus 14%. So now that change in strain relative is about 17%, and that breaks the threshold to be a meaningful reduction in global longitudinal strain.
Can I go back to that one image? Just something that strikes me, and I've seen that very frequently. Want to have your opinion on this? That if strain gets less, it usually starts at the base as well. Have you seen this pattern very frequently?
Yes, it does. I can't explain to exactly why that's the case. As we know, there is a small base to apex gradient in strain, where strain's a little higher at the apex than the base, the opposite to...
Right. But maybe with dysfunction, this gradient actually gets larger, meaning that sometimes you even see hyperdynamic function at the apex, even in chemotherapy, while the base gets worse and worse and worse and worse. So I think alone the bullseye display is just so impressive because it already shows you that something is going on here.
Yeah, you nicely appreciate that. That's a very good observation, Tommy, where we can see this reduction in strain more in the basal segments, where these apical segments remain somewhat preserved.
Yes.
So we did see this sort of threshold reduction, and I just wanted to share with you sort of our cardio-oncology screening strategy. We like to look at obviously baseline evaluation of the patient, and then some objective parameters of ventricular function, ejection fraction, longitudinal strain, and we do look at a biomarker. We do measure troponin. Of course, if they are abnormal at baseline, and I just put in brackets the global longitudinal strain less than minus 18% in asterisk, because remember it's a negative number, so it's really greater than minus 18, but it's so a number of minus 15 or 14 is worse than minus 18.
It's always a little bit confusing.
So that's why I put it in brackets. I asterisk this so you're aware that it's really greater than, but a smaller number. And of course, if they're abnormal, we want to see these patients even before they begin their chemotherapy in our cardio-oncology practice. If their ejection fraction is normal, strain is normal, their biomarker troponin are negative, then we'll follow these patients every 3 to 6 months. And that's a wide range. It really depends on the cumulative dose of the drug that's being used, what medications are being used, what chemotherapy agents and are they being used in combination, what risk factors the patients might have. But if we see a drop in ejection fraction by 10% to a value less than 53, then that does represent chemotherapy-related cardiac dysfunction. If that is a relative drop in strain compared to baseline less than 8%, we said that's not clinically perhaps significant, but a subclinical LV dysfunction, a strain greater than 15%, that is significant, and we generally begin cardioprotective, neurohormonal modulating, goal-directed therapies, ACE inhibitors, and or beta blockers.
So you would actually really have therapeutic consequences from the reduction in strain?
Yes, absolutely, that's true.
I think that is a very, very good point here. So it's not just to find out if he has dysfunction, but it also has therapeutic implications.
That is correct.
Yeah.